So, and Dr. Butler and others in this group were also involved in the ventral hernia working group, who, as you've already heard today, categorized patients based on their risk for surgical site infections. I think this is a very useful exercise. And concluding largely the grade 1 patients who I would say are undergoing largely mitigating other circumstances, simple abdominal wall reconstructions, have a low risk of surgical site infections, and that may justify the use of synthetic meshes. Grade 2 patients, moderately complex, probably in the middle. Grade 3 and 4 patients, more complex, what I would consider complex abdominal wall, even without the other local surgical factors, are at high risk for surgical site infection, and I think this justifies the use of biologic mesh in most of these cases. The indications for biologic mesh, I think, and the contraindications for synthetic mesh sort of converge in the area of complex abdominal wall reconstruction, and this is gross contamination, inadequate soft tissue coverage overlying mesh, a bridge repair because of the proximity to the outside world, and direct contact with bowel. And I would include an inadequate posterior sheath. We talk a lot about the retrorectus space. In our oncologic group, there's a lot of radiation to the posterior sheath. There's a lot of peritoneal stripping. Frequently don't have a good retrorectus space. And we know from the information that Dr. Janis presented today that an intraperitoneal approach has a similar complication profile and recurrence profile to the retrorectus space. So this is a very good option if that's not a great layer for you, and patients who have significant medical comorbidities. Recent dogma has sort of challenged some of those doctrines, but this study does boast a 4% explantation rate, which I would still consider high and undesirable.